Kienbock's disease. Definition: Kienbock's disease refers to avascular necrosis of the lunate, leading to progressive wrist pain and dysfunction. So this is diagram. Okay, bone of hand. Here is the lunate bone. This is lunate bone. You can see here. Now, etiology. Multifactorial causes including negative ulnar variance, vascular insufficiency, repetitive trauma, and biomechanical stress. Epidemiology. Most common in males aged 20 to 40 years, often affecting the dominant wrist. Pathophysiology. Blood supply variations. The lunate has three vascular patterns: Y pattern, X pattern, I pattern, with 31% of patients at high risk for vascular necrosis. Now, stages of necrosis. Disruption of blood supply. Okay, thereafter bone infarction, there is bone infarction, then central necrosis, then there is microfractures, then there is lunate collapse. Progressive deformity leads to wrist instability and degenerative changes. Clinical features. Symptoms: dorsal wrist pain, often activity related, reduced grip strength, limited wrist motion, and tenderness over the radiolunate facet. Now talking about physical examination. There is wrist swelling, decreased flexion, extension, arc, and pain on palpation. Now diagnostic approach. Radiographic features. Stage 1. No visible changes on X-ray. MRI shows early necrosis. In stage 2, sclerosis of lunate, possible joint leveling procedures. On stage 3A, there is lunate collapse without scaphoid rotation. In stage 3B, lunate collapse with fixed scaphoid rotation. In stage 4, there is degeneration of adjacent intercarpal joints. Next, imaging modalities. Here we will see X-ray. X-ray detects sclerosis and lunate flattening. MRI, most sensitive for early diagnosis detection. CT scan, useful for assessing trabecular destruction and lunate geometry. Management strategies. Non-operative, NSAIDs immobilization and activity modification for early stage disease. Next, operative. Joint leveling procedures. Radial shortening osteotomy or ulnar lengthening. Okay, for stage 1 to 3. Proximal row carpectomy, STT fusion, or SC fusion for stage 3B to 4. Wrist fusion or limited intercarpal fusion for advanced degeneration. Now MCQ based on etiology. Okay. Which of the following is the most important predisposing factor for Kienbock disease? So what is the predisposing factor? A. Positive ulnar variance. B. Negative ulnar variance. C. Increased vascularity of the lunate. D. Excessive wrist flexion. What is? Answer is option D. That is negative lunate variance. Okay, now explanation. Negative ulnar variance leads to increased loads on the lunate, reducing its vascular supply. This predisposes the lunate to avascular necrosis, especially in individuals with poor intraosseous blood supply. Positive ulnar variance is associated with ulnar impaction syndrome, not Kienbock disease. Now MCQ2 related to blood supply. Which of the following best describes the vascular supply to the lunate bone? Option A. Single blood vessel from the radial artery. Option B. Dual supply from palmar or dorsal branches. Only palmar supply in all individuals. No vascular supply to the lunate. What is the answer? Answer is option B. Dual supply from palmar and dorsal branches. Explanation. Normally the lunate receives blood supply from both palmar and dorsal intercarpal arteries. However, in 20 to 31% of individuals, the lunate is supplied only by palmar vessels, which significantly increases the risk of avascular necrosis, Kienbock disease. Now question number 3 based on imaging. Which imaging modalities is most sensitive for detecting early stage Kienbock disease? Option A. X-ray. Option B. CT scan. Option C. MRI. Option D. Bone scintigraphy. What is this? Answer is option C. MRI. No explanation. MRI is the most sensitive imaging modality for detecting early ischemic changes in the lunate. X-ray is useful for late stage sclerosis and collapse, but it may miss early disease. CT scan is better for trabecular destruction assessment, but MRI detects early necrosis. Bone scintigraphy helps detect bone metabolism changes, but it lacks specificity. Now question 4 related to staging. Which of the following correctly describes the Leachman staging of Kienbock disease? Option A. Stage 1. No radiographic changes. MRI shows early necrosis. Stage 2. Lunate collapse without scaphoid rotation. Option C. Third A. Lunate collapse with fixed scaphoid rotation. Option D. Stage 4. No adjacent joint degradation. What is answer? Correct answer is option A. Stage 1. No radiographic changes. MRI shows early necrosis. Explanation. Stage 1. Normal X-ray but MRI shows bone marrow edema. Stage 2, the sclerosis of the lunate with fragmentation visible on X-ray. Stage 3, lunate collapse without scaphoid rotation. Stage 3, lunate collapse with fixed scaphoid rotation. Stage 4, degeneration of adjacent intercarpal joints. MCQ 5. Management. Which surgical procedure is most appropriate for stage 2 Kienbock disease with negative ulnar variance? Option A, wrist fusion. Option B, proximal raw carpectomy. Option C, radial shortening osteotomy. Option D, STT fusion. Answer is radial shortening osteotomy. Explanation. In early stage Kienbock disease with negative ulnar variant, radial shortening osteotomy reduces pressure on the lunate and improves vascular supplies. The wrist fusion is used in end-stage degeneration. Proximal raw carpectomy is reserved for advanced collapse stage 3 to 4. STT fusion is performed in case of carpal instability, not early Kienbock disease. That's for all.